I'd like to thank the SAGES organization and the session chair for the opportunity to present on making the pouch and managing the hiatus when performing a gastric bypass. I have nothing to disclose. Looking at the trends in performance of gastric bypass globally, while it continues to remain the most commonly performed procedure, in fact, the relative percentages of procedures is actually declining. And this can be seen in most countries, except really for those that are categorized within the Latin South American group, wherein a gastric bypass actually comprises about 65% of the total bariatric procedures in 2013. So in making a pouch, obviously there are things to consider, including pouch size and stoma size, because ultimately these do affect both weight loss and common complications after gastric bypass, and more specifically, marginal ulcers or strictures. So to understand the sort of global approach to making pouches, Kumar and their group actually surveyed 651 bariatric surgeons with a cumulative experience of about 158,000 cases, and they found that when asked about the distance below the diaphragm, that surgeons start the gastric division, more often than not, it was about 5 centimeters below the diaphragm. Most surgeons actually used an OG tube to size the pouch, and the most commonly used tube size was 36 French. Madden and their group actually surveyed members of the American Society for Bariatric Surgery asking similar questions, and they found that most surgeons actually just measure a distance from the GE junction, followed by measuring below a certain number of vessels. In sizing the stoma, the Madden paper actually explicitly asked this question and found that most surgeons use a bougie size. While the Kumar paper actually didn't ask this, you can infer it based on what they, based on the information about gastrojejunectomy technique. And what they found was that most surgeons used a linear stapler, the most common stapler being 45 millimeters. Along the same lines, the Madden paper asked a similar question, and there was really no difference in terms of percentages between circular stapler and linear stapler. However, the 21 millimeter circular stapler was the most commonly used when circular staplers were used. So, how do these aspects of the gastric bypass, specifically making the pouch and sizing the stoma, how do they impact weight loss and how do they impact marginal ulcer or stricture formation? So starting with weight loss, this was a recent systematic review looking at this question. And out of 14 studies that actually examined pouch size, 5 actually determined that a larger pouch size was proportional to a lower weight loss. However, 9 saw no effect. Examination of stoma size, looking at 10 studies, demonstrated that 4 of them showed that a larger stoma was proportional to a lower weight loss, but 6 of them showed no effect on stoma size. So what can be concluded? Really that a larger pouch and stoma may be associated with poor weight loss. Now, what about ulcer formation? So in terms of pouch size and ulcer formation, we do know that there are parietal cells present in the proximal stomach. However, this particular study demonstrated that they're actually present in pouches as small as 2 by 3 centimeters. This study demonstrated that there's a 14% increased risk of ulcer formation for every centimeter of stapler used. And so really, the ultimate conclusion is here is really just to make your pouch as small as possible, 15 to 30 mils. In terms of formation of the gastrojejunectomy and ulcer formation, and I use this as a surrogate for sort of the stoma, this systematic review demonstrated that foreign materials are found in about 1/3 of marginal ulcers. However, when comparing hand-sewn versus linear stapler versus circular stapler anastomoses, this particular study, which is the largest series to date, demonstrated no difference. So while we know that there is some association between foreign material, especially non-absorbable suture, there's really no clear consensus on this aspect of pouch formation. In terms of stricture formation, similarly, there's very equivocal evidence with respect to the way the GJ is formed. This study did demonstrate that there is a 26% decreased risk of strictures when using a linear stapler versus a circular stapler, but it did not reach significance. Further, in reference to that study I cited previously, they also looked at stricture rates between hand-sewn linear stapler and circular stapler, and again, no real difference. Staple height, however, is a little clearer. This study, recent study actually, demonstrated that circular staplers with a staple height of about 4.8 millimeters had a much higher rate of stricture formation. It was much more significant than those with a 3.5. So obviously there's a lot of variation with respect to not only how the pouch is made, but how the stoma is formed. And I'm just going to show you my approach just to highlight things that I think about when I'm actually creating the pouch. So from the get-go, I actually used vessels along the lesser curvature to determine my pouch length. I get into the lesser sac being sort of cognizant of dividing all those posterior attachments, because that's going to facilitate retraction of the pouch to ensure I get equal retraction on the anterior and posterior wall of the stomach. I then divide the hepaticogastric ligament using a stapler. And once complete, I perform a distal gastrotomy through which an anvil is passed by attaching it to a suture and grasping it with a reticulating Maryland. The key at this point, or what I'm thinking about, is actually where the tip of that Maryland is going to come. And I try to align it as close to the end of that staple line as possible, because that will ensure that my transverse staple line that eventually will cross that will clear the anvil so that my pouch width is not too wide. The suture is grasped with a bullet, and the anvil is then tucked through that distal gastrotomy and then brought out through the proximal gastrotomy. Once that distal gastrotomy is closed, we then proceed to actually forming the pouch around that anvil. First thing is to sweep the anvil towards the diaphragm and place that first transverse staple load. The key here is to ensure that the upper margin of that linear staple load abuts the anvil as closely as possible. So you can see I'm really pulling down the tissue to ensure that approximation. So abuts it as closely as possible in order to ensure that you don't get a double staple line when you dock the anvil with the circular stapler. Subsequently, I start dissecting all the attachments posteriorly towards the cardia in order to identify my landing zone. Doing this not only allows me to ensure that my pouch is as narrow as possible, but also that there's less tension when I create that final gastrojejunostomy. So once I find the area where I want to land, proceed by using reinforced staple loads. And for every staple load that I place along that vertical margin, once placed, I purposefully retract the fundus laterally to ensure, again, that my pouch is as narrow as possible. Sometimes there's a little additional dissection at the frontoesophageal ligament that's required. And then once the final stapler is fired, be sure to divide any of those final attachments. Now here, what I'm showing is that there was a little bit of extra fat on the anvil. And at this point, I also ensure that I dissect all that fat off the anvil to ensure even tissue thickness when I'm actually creating the gastrojejunostomy. So all those adhesions are taken down. And in doing so, I also have found that that vessel there is actually not traversing the margin of the anvil, and actually, as you'll see at the end, can be easily tucked in and would be included in the donut. So once that's complete, the spike is taken off the anvil, and I proceed with the remaining gastrojejunostomy. So now switching to managing the hiatus. Again, referring back to this global survey, approximately 66% of patients do perform a routine crural closure, but the approach to the closure is pretty varied, anterior, posterior, or no preference. So the question becomes, do we really need to fix them? We know that hiatal hernias are common in patients with obesity. Thus, there's a cited literature range of about 5 to 50%. A more recent study demonstrated that the prevalence is actually about 37%, with the more prevalent being the smaller hiatal hernias. And this group also showed that hiatal hernias were more likely to be associated with GERD. We do know that gastric bypasses improves GERD symptoms significantly. However, as a recent study has also shown that we are much less likely to close a hiatal hernia doing a gastric bypass than doing a sleeve. Given that about 50% of patients with persistent GERD symptoms after gastric bypass are diagnosed with a hiatal hernia, perhaps it's time to revisit this idea of optionally fixing the hiatus when we do a gastric bypass. So in summary, there is tremendous variation in gastric pouch formation and really no consensus on managing the hiatal hernias. We all have this goal in mind in terms of maximizing weight loss and minimizing complications, but perhaps the take home here is that there's this opportunity for standardized reporting to facilitate comparison of outcomes to eventually find what is the best approach for each individual patient.